Delighted to be here today to be able to share some of the results of our recent study which took place in rural Malawi and examined the benefits of using a behaviour-centred approach to implement a wash and complementary food hygiene intervention to reduce diarrheal disease. Diarrheal disease, as we all know, continues to be a significant cause of morbidity and mortality in low and middle income countries. However, an often under-regarded area of fecal-oral transmission is food, and particularly complementary foods. Recent evidence has shown that the majority of foodborne disease burden lies in sub-Saharan Africa and South and Southeast Asia, with a large proportion of that lying with children under the age of 5. So with this in mind, we sought to develop a behaviour-centred food hygiene and wash intervention to determine if their relative impact on diarrheal disease reduction in this setting. Our research took place over 2 years from 2017 to 2018. We undertook extensive formative research over 6 months using the HACCP and RANIS models, which examined our social, physical, personal, and psychological contexts. That information was then used to develop a community-based intervention with our stakeholders here in Malawi, and then we implemented the intervention over a 9-month period before conducting the inline evaluation. This was a before and after trial with a control, and we called it Banja Ukhondo, the hygienic family, as although the mothers were the primary caregivers, we did recognise that men had a very important role to play in terms of household development and allocation of household funds for hygiene materials. Treatment Group 1 undertook food hygiene only in combination with hand washing with soap, as hand washing is such an important component of food hygiene. And Treatment 2 also included faeces management and water management. Hand washing with soap addressed hand washing at critical times, as well as households developing and putting in place their own facilities and ensuring access to soap and water where necessary. That overlapped then with food hygiene and the need for washing utensils and storing utensils safely, ensuring food preparation and storage was done effectively, including reheating, and feeding children hygienically as well. In terms of faeces management, that focused on not only human faeces, including those of children, but also of animal stools, as this was an area which has households own a lot of livestock. And then we had safe water storage systems where we did not provide any kind of water treatment, but just looked at actual safe water management within the household. The intervention was delivered through a number of mechanisms, including open days at the beginning and end of the study. And we had alternating weeks, 1 week with cluster meeting where women would come together in a similar style of a scaling up nutrition caregiver group or village health committee group. And on the alternating weeks, the identified community key informant would undertake household visits for one-to-one follow-ups. We also provided households with personal and environmental prompts and nudges. So personal being perhaps a bracelet that reminds people to wash their hands. The bib that you can see on the baby there was used to remind mothers to wash their hands and feed the baby hygienically, and other things such as buntings, which could be put around the house. The intervention was developed to be context appropriate. Households in this area all of them live on less than $1.90 a day. It was based on our findings from the RANIS survey, so focused on using normative ability and self-regulation factors. We made sure that the activities were interactive and fun and illustrative. So for example, in the top corner there, you see a mother and child with paint on their hands. We used those in a game to show how bacteria can transfer. And then they made a plate which said, don't forget to wash your hands, that they could take home to remind themselves in their household setting. And we also ensured that content was repeated across all of the modules and even between meetings and household visits, because not every woman could attend every meeting and we needed to make sure that they received all of the messages. So in terms of intervention exposure, we had 1,000 children initially enrolled, of which we lost 16% by the end of the study. You'll see here that we did not get full attendance at any of the cluster meetings or household visits. And that's one of the reasons, as I mentioned, that we ensured there was repetition of messages going across meetings, and that we built up social capital and support within our cluster ladies so that they could share with their friends who could not attend, as they may have gardening duties or other household duties on that day. In terms of the primary health outcomes, at baseline, we had no significant difference between the control and treatment groups. However, at endline, there was a significant difference between the control and both treatment groups of around 13 percentage points. So if we look at the control group having about 20% diarrhea, then we're looking at the treatment groups dropping down to approximately 7% prevalence of diarrhea by the end of the study. We can see from that, however, that food and hand washing with soap had the most significant impact on disease reduction, and having then conducted probability modelling, we identified that the intervention as a whole was solely responsible for observed changes, and there were no individual predictors that stood out. This sits well with some of the findings of the recent WASH benefits and SHINE trials, which also argue that we need marginal gains from multiple components to reduce fecal-oral transmission of diarrheal diseases. We have other outcomes recorded as well, which I don't have time to touch upon today, but importantly, there were a number of non-health benefits reported by caregivers, including building social capital and relationships with other women within their communities. And we also noted significant improvements in both behaviour change and hygiene infrastructure at households, which contributed towards this reduction in diarrheal disease. The implications of this study, from our perspective, are that a behaviour-centred design approach can have a significant impact on diarrheal disease reduction, and food hygiene and hand washing with soap are incredibly important to reducing diarrheal disease, and so should be integrated into any transformative programs, including nutrition and agriculture programs, fecal oral exposure. These environments are extremely highly contaminated with feces, both from humans and animals, and we need to look at multiple pathways and controls. Our contact time with caregivers through cluster groups and through household visits, we think had a more effective impact on uptake. And we also showed that we could use these local structures such as caregiver groups for effective implementation. We would call upon other people to also recognise that they should measure the wider benefits of these interventions rather than just the primary health outcomes when undertaking these studies. So lastly, just to say thank you to the fantastic team who implemented and took part in the Banja Ukhondo study, and some links there to the publications that have come out from our research so far. Thank you very much.